So we're going to record the didactic portion. There's going to be a discussion at the end, which will not be recorded. And we'll announce when the recording stops. Hi, good evening. I'm Dan Pomerantz. I'm the Hudson Valley governor. So my region covers the area from the Bronx border all the way up to Canada. And as far west as Cooperstown. It's an odd-shaped district, but happy to be the governor. Really love the work I do with ACP. My day job is at Montefiore New Rochelle Hospital down here in Westchester, where I direct our palliative care service, and I'm an associate program director in the internal medicine program. I'm going to be hosting this event tonight with two of my colleagues, the Hudson Valley Capital District President, Dr. Carolyn Gomez de Cesare, whose day jobs are at Bassett Healthcare, where she's the network director of well-being, as well as a clinician. And she just led a group there that won an award from the AMA. So congratulations. Thank you for all of your good work. Dr. Gomez de Cesare is also a member of our well-being committee, as is our other ACP representative here tonight, Dr. Nandini Anandu, who is a hospitalist at Northern Westchester Hospital in Mount Kisco, the Hudson Valley South District President, and also a member of the Wellbeing Committee. Our Wellbeing Committee programming is really wonderful. The two of them have been instrumental in implementing some really great programs. Please check those out. And now I'd like to introduce our speaker tonight, Dr. Megan Gerber. Is a general internist with a career-long interest in improving health after trauma exposure. Early in her career, she began working in Cambridge, Massachusetts on domestic violence-free zone, which led to an interest in intimate partner violence. She completed an MPH and postdoctoral fellowship in intimate partner violence research. And after practicing for a number of years, saw that that wasn't enough just to respond to one form of trauma. And there was a need to adapt primary care settings to be more healing for survivors of all trauma. She's the editor of a textbook, which is excellent. It's Trauma-Informed Healthcare Approaches, a Guide for Primary Care. Don't have a copy to hold up, I apologize. Dr. Gerber is a native New Yorker. She joined the faculty at Albany Medical College earlier this year, where she's a professor of medicine, division chief of general medicine, vice chair of the Department of Medicine for Faculty Development, and an advising dean. She has continued her affiliation with the VA, where she's long held regional and national leadership roles in women's health. She's also a very interesting presence on Twitter, which is where I first met her. And I'm going to claim this much credit for her being here tonight because I suggested that she get her FACP, and here she is. So thank you, Dr. Gerber.
Thank you, Dan, for that wonderful, kind introduction, and thank you all for inviting me and also being so welcoming when I moved to New York. I'm going to go ahead and share my slides. Hopefully, sometimes this is the part that doesn't always work. Let's see. I had that all queued up properly. Can everyone see my slides? Okay, great. So tonight I'm going to be speaking with you about trauma-informed care in this current era. And I really do want to have a good conversation or a robust conversation. And so I'm going to speak for less time than I normally would when I give these kinds of presentations. So I may flip through some of the slides really quickly, but I thought that they should be here for your reference. Anybody is welcome to email me after this talk. I'm also happy to share any of the book chapters. You don't have to go out and buy the book. None of us was paid for it. And we're very happy to share it with anyone who's interested in reading it. So some of the learning objectives for tonight, we always want you to be able to recognize the long-term health impact that adverse childhood experiences and other traumas have on health. Not all of us are here tonight are internists. I know that I see some students, and I'm really thrilled that all of you are here. Anybody who works with adults is really has to be concerned about the childhood of adults, because that is when people are formed and when their brains develop. I'd like you to develop familiarity with the principles of trauma-informed ways of adapting language and physical exam skills to promote trust and healing. You know, any one of these learning objectives could be an entire talk. And then we can consider together, and then you can individually consider ways to apply principles of trauma-informed care to your practice during these challenging times. I still have an affiliation with VA, so I need to let you know that these are my views and my views only. And then those of you who have heard me speak before know that I frequently will challenge you to leave here today with one idea for changing your practice. And I will do the same. And I may actually learn an idea from all of you. So when we define trauma, there are many different ways of defining trauma. I really like this definition from the Substance Abuse and Mental Health Services Administration. Now, why SAMHSA? Many of you who've worked with SAMHSA know that many believe that trauma is the original gateway drug. So I find it very meaningful that SAMHSA is a leader in trauma-informed care. So I won't read you the whole definition, but trauma is an event, a series of events or a set of circumstances that are experienced by an individual as harmful or life-threatening with lasting adverse effects on the individual's function or well-being. So trauma is actually individually defined. It's not defined by us, it's defined by the individual who experiences it. It's multifaceted as well. Trauma can be a single traumatic event. It's more often multiple events or exposures over time. I'll note that interpersonal violence or violation, especially at the hands of an authority or trust figure, is especially damaging. So we can think about childhood maltreatment, military sexual trauma, where an officer or a unit member is supposed to be keeping that soldier safe. Elder abuse is another example. So this is a particularly harmful form of trauma. Structural violence, systemic racism, things that are ways in which social structures rather harm or otherwise disadvantage individuals are traumatic. And this would, of course, also include ageism, which was rampant during the pandemic. Trauma can be collective, historical, generational. We don't have enough time to talk about those tonight. And then, of course, pandemics, natural disasters, war, these things are, of course, traumatic. But trauma is not always going to be measurable. And it's not always going to be visible to us. And that's something we have to remember. When we do measure trauma, when we do look at government-funded, large-scale population estimates of trauma, this comes from the CDC National Intimate Partner Violence and Sexual Violence Survey. We call it NISVIS. We see, and this is 2015 data, was the most recent data not too long ago. So IPV, intimate partner violence, is very common, and actually it's quite common in men. IPV takes more severe forms in women and can be more likely to result in death. Sexual assault is relatively common. Look at sexual assault under the age of 18. And again, these persons sampled are English and Spanish speaking, they have telephones, they answer their phone. So these rates probably greatly underestimate the true rates of trauma in the population. And then finally, look at PTSD symptoms for the entire population. Again, this is not a clinical diagnosis of PTSD, but more than half of women sampled had PTSD symptoms. I'll note that NISVIS does not sample non-binary persons, and this is a major limitation of this kind of data. So ACP has become more interested in childhood exposures, and I was told by ACP leadership that is because our medicine pediatrics colleagues have pushed that. So thank you to those of you out there who have really encouraged us to think more about childhood. So if I had more time, I often will show you a picture of Vincent Felitti, who is himself an internist. He was the principal investigator on the original adverse childhood experiences study out of Kaiser. The first study was published in 1998. They interviewed 17,000 Kaiser Permanente patients who were mostly white, most all employed, well-educated. And basically the finding was that after controlling for demographics and for health behaviors, adverse childhood experiences result in greater odds of diabetes, ischemic heart disease, cancer, COPD, cerebrovascular accidents, and many other diseases have been linked to adverse childhood experiences. And certainly premature mortality has as well. So ACEs are a variety of adversities ranging from something as common to divorce, from divorce to something like childhood maltreatment, physical or sexual maltreatment, an incarcerated parent. So there are 10 ACEs that go into the ACE score. ACEs have been conceptualized as a public health issue, like an adverse health exposure. And many states are now including the ACEs survey in their behavioral risk factor surveillance data. Health professions training is lacking. Some of the medical students in the meeting tonight have reached out to me because they are trying to incorporate curriculum at their medical schools. So a lot of the push for this is coming from students. I will also point out just very quickly that Black children have the highest odds of exposure to adverse childhood experiences. This is not because Black parents are not good parents. It's because of the differential exposure to things like mass incarceration that Black families experience. So it's fair to say that many health inequities and disparities begin early in life. I'll point out really quickly that my colleague Peter Kronholm in Philadelphia has proposed an expanded ACEs that includes exposures that urban populations that are not white, not always well insured, not always well educated, are more likely to experience. So witnessing community violence, experiencing racism or discrimination, living in an unsafe neighborhood, living in foster care. And I won't belabor the slide, but basically when you compare the sample from Philadelphia, the more diverse urban dwelling sample, to the original largely white Kaiser sample, you see that these folks living in urban settings, less likely to be insured or employed, are more likely to have an incarcerated household member, a mentally ill household member, or to experience emotional abuse. So the traditional ACEs are higher, and then expanded ACEs are really important and something that we always have to think about when we interpret these studies. So please think about trauma and health as a dynamic process. Trauma is not just this bad thing that hits you and changes you. There are protective factors, and you'll see them over on the left, and then there are risk factors. And many of the things that are protective are things that we can control. So having well-resourced, safe communities, having evidence-based treatments available, trying to provide financial security for families. Many risk factors are harder to modify: gender, young age, minority status. But in general, protective factors are often forgotten when we think about trauma. And we always have to ask our patients, what makes you strong? And then hovering in the background is epigenetics. Some people are more predisposed to experience health effects after trauma. And again, we can talk about that more later if we have time. This is a wonderful documentary. It's called Broken Places, and it follows children who had very difficult childhoods to adulthood. And some of the kids are doing really well as adults and others are not. And there's this beautiful quote from Ernest Hemingway in the ad: "The world breaks everyone, and afterwards many are strong at the broken places." So we have to remember that our patients are strong, and we need to find out what makes them strong. Trauma and ill health is a whole area of research. This word cloud is just my attempt at saying this is way too complex for this presentation. It's a fascinating literature, and anybody out there interested in getting a PhD should think about looking at some of this. I will tell you that one of the best models for understanding the effects of trauma on health is that of allostasis and allostatic load. So allostasis is the integrated balance of the CNS, the endocrine, metabolic, and immune system. So over on the left, you can see that there's prolonged activation from chronic stress and repeated traumatic exposure. So witnessing community violence, experiencing structural racism, leading to wear and tear on the body, and then leading to allostatic load. So again, there are common clinical ways of measuring it. There are experimental ways, but we know that stress does increase allostatic load. I contemplated taking this slide out. I really like this slide because it shows you that allostatic load is linked to socioeconomic status, to social determinants of health, to adverse childhood experiences, and to racial disparities. These are all separate studies. And so when you're thinking about this, you start to think, wow, these are the things that lead to or are associated with health inequity. So there really is a lot of linkages between the so-called social and environmental exposures and ill health. They seem to work through both biological mechanisms and through adverse coping or poor coping behaviors. We've had a really rough year and a half. This collage just keeps getting busier and busier. Sandro Galea, our dean at BU, when I was there, coined 2020 the Great American Trauma. COVID-19 is a mass casualty event, and all of you have been witnesses to it. Some of you have actually lost colleagues and family members, and I am so sorry for your loss. And actually, I didn't say at the beginning of the talk, so let me just stop and say that some of these topics are very disturbing and difficult. So please take care of yourself. You can turn your camera off. You can take a break. You can even leave the presentation. Reach out to a colleague or a friend if any of this is upsetting. But we all have lost someone. We've all watched patients die, potentially unnecessary, awful, lonely deaths. And it's just been a really, really difficult almost 2 years. I won't go over this whole slide. Probably most of you could have written this, but basically things like COVID-19 can be, events like COVID-19 can be newly traumatic, or they can be very re-triggering. I wrote a narrative piece that was published in the Journal of General Internal Medicine because I met a veteran outside the hospital one day and I asked him how he was. And this was March of 2020, it was peak pandemic. I said, "How are you, sir?" And he said, "I feel like I am in Vietnam." So the pandemic was very re-triggering for a lot of people. It was re-traumatizing for many. It still is. Those with pre-existing vulnerabilities like financial insecurity and mental health issues are experiencing very difficult times. There have been increased reports of intimate partner violence, elder abuse, childhood maltreatment. These are documented. And a lot of this has to do with unemployment, with increased stressors, with people being cooped up in homes. Our seniors who could go to adult day often aren't able to go. Our children who had aftercare often aren't able to go. So a lot of really scary things have been going on. The climate around all of us as healthcare clinicians is just so, it's morally distressing. I drive by this billboard every day. Those of you who live in Albany have seen it. They're actually worse billboards. So here we have COVID, sort of highlighting inequities, structural racism, ageism, historical traumas. BIPOC persons are dying at higher rates. We have seen human-made and natural disasters. We've seen worsening mental health. We've seen politicization of health measures in public health. And then here we are in healthcare with staffing shortages. Many of us are burned out. We've experienced our own illnesses. We've experienced PTSD, depression, suicide, burnout, all sorts of things that were difficult in medicine before have become more difficult. I've been talking about the corporatization of behavioral health care. Many places in the country are having trouble hiring therapists, and we're losing healthcare workers to early retirement. So we're all coming into thinking about trauma-informed care, already experiencing all these difficulties. And I just have to remind us that healing environments can be frightening. They can easily cause re-traumatization. Those who have survived trauma find medical care very difficult. Many minoritized individuals, LGBTQ individuals, avoid healthcare until it's absolutely necessary to go. Healthcare requires vulnerability, loss of privacy and control, removal of clothing, vulnerable positions, physical positions. And we see a lot of displaced anger in our medical offices lately. Trauma-informed care is a strengths-based approach. It really does seek to maximize safety, and it understands that traditional service delivery models, no matter how well intended, can trigger silence and disempower. There is no single guide. There really isn't a book that will help you. You have to continuously reappraise what you do, either as an individual or a health system. These are the core principles of trauma-informed care, and we'll touch on these. I do also want to remind you really quickly, this comes from work by Sheila Raja, that screening is at the top of the pyramid. It's not the first thing you do. The fundamental aspects of trauma-informed care are rooted in patient-centered communication and care. So screening might not even happen, and we can talk about that some more during the discussion. Screening is a later thing that you do when you're ready to screen. So we see these signs for universal precautions all over our healthcare systems. We should be practicing universal trauma precautions. So trauma-informed language, really important. You can get in the habit of this. It just takes a little bit of practice. And honestly, so what if you slip up? You'll have the humility to apologize. So whenever possible, use neutral terms, table instead of bed, drape instead of sheet. And there's some really great lists out there that I can share. Avoid personalizing things. So we've all said, open your mouth for me. Avoid use of for me. Some commonly used terms can come across as orders. So relax can feel very triggering to some patients. So instead you employ suggestions like, some find it helpful to take a deep breath during this part of the exam. Person first language is really important. It gives back control and personhood to the individual in your exam room. I always slip and say diabetic, and I just kick myself. And I've actually apologized to patients. So instead of diabetic or alcoholic, this is a person living with diabetes. This is a person having problems with alcohol or experiencing problems. A lot of people hate the word victim. Person who experienced, survivor is more trauma sensitive. I just have to stress, it's not necessary to ask patients to disclose details of their history to practice trauma-informed care. There's a wonderful, it's not a validated screen. It's just something that our colleague Jeff Milstein from Penn came up with. Have you experienced anything that makes seeing a doctor difficult or scary for you? And then this from Eddie Mochtinger at UCSF. Difficult life experiences like growing up in a family where you were hurt or where there was mental illness or drug or alcohol issues or witnessing violence can affect our health. Do you feel like any of your past experiences affect your physical or emotional health? And there are a number of others that are just gentle ways, especially if you're suspecting trauma, of bringing it up with patients. Physical exam, this could be its own entire talk. Ask your patient, when you have an exam of this kind, what helps you feel comfortable? Ask permission or consent for the exam. You can ask a patient to disrobe to their level of comfort. Avoid a personalized language, as I said, and also I narrate and ask permission. So in order to examine the thyroid gland, I will need to place my hand on the front of the neck. Is that okay? Many of us in the meeting tonight were taught to stand behind the patient with our hands on their neck. It isn't necessary to do that to examine the thyroid. So again, reconsider your traditional physical exam when possible, shift clothing aside. Offer a chaperone. Don't just offer chaperones when you're working with a woman who's having a pelvic exam. If someone seems a little bit off or a little bit jittery, if you have the ability to offer a chaperone, that's a wonderful thing to do. This is a busy slide and it's really here for reference. And again, I'm happy to share this information afterwards, but always avoid unexpected physical contact. Ask your patient if they have concerns. Don't just switch off the lights without warning someone. Sometimes patients feel anxious in the fully supine position. So you might actually want to offer to prop the head up if that's something you can do. Invasive exams, again, this could be an entire talk, but I do a lot of women's health care. I deliver a lot of women's health care, and I will often ask women what has helped them with a pelvic exam before. Always make sure the patient knows that he, she, or they is in charge of an exam and that it will stop anytime he, she, or they ask. Warn about ambient sounds. The speculum will click when I open it. So these are just some tips. I always do like to cover dissociation because we don't get a lot of material on dissociation as general internists or family medicine or medicine pediatrics professionals. So if you see a patient who's just not engaging, not making eye contact, they're kind of looking around the room, they seem a little bit out of it, they're minimizing symptoms that might require an invasive exam, physically withdrawn, quiet, or frozen, really consider dissociation. I won't go into full detail on the slide, but the most common form of dissociation is kind of a mild spacing out in which the patient might tell you later on that they had a memory gap. Again, really, if you think someone is dissociating, it would be really helpful to stop what you're doing and ask them if someone else can be in the room. You may have times when you will feel that you need to bring in a chaperone without permission, and we can talk about that later. If you have established that your patient is dissociative, and certainly if you have the good fortune to have a behavioral health or mental health clinician in your office, you could certainly have that person come in with you and assess the patient. Many of us don't have that. So you would stop whatever you're doing, whether it's an exam, whether it's obtaining consent. And I've seen this happen when patients are consented for invasive procedures. Ground the patient. So use simple language. Those coarse white washcloths that are all over hospitals are really great for squeezing and grounding because they're very textured and stiff. Focus on simple concrete tasks, count out loud, focus on breathing, discuss color of the room. Do not touch a patient there, don't do that when someone's dissociating. And try to avoid things like calling a behavioral code because that can just completely frighten and activate the patient. I don't think that we have a lot of time to talk about telehealth, but I'll just simply tell you that there's a big literature on telemental health. So we know that telehealth is acceptable to trauma-exposed patients, and often that virtual space created by combined physical and psychological distance can create safety and transparency. So know that you can do telehealth effectively with people who've experienced trauma. There are many challenges during COVID. I know I was very spoiled at the VA and was able to get tablets for my patients, and we just don't have that outside of VA. But again, just be aware of these issues with telehealth. Some quick tips on telehealth. The team had wanted me to cover it. Always wear, and I'm not today, but wear headphones or earbuds as the clinician and the patient should as well. And I'll explain that in a minute. look directly at the camera. So right now I'm looking at the camera as I'm speaking to you. Now I'm looking at the patient. So your gaze, and I'm telling the students this when we do mock interviews for residency season, look at the camera, and you can actually put a sticky next to the camera if you're having difficulty remembering to look at it. So when you look at the patient, you're looking away from the camera. A person who's experienced trauma may find a lack of eye contact more unsettling. Another, a lot of tips here, but another one is to count 3 seconds before you respond, because you can come across as cutting people off. There is a lag time. Always allow the patient to choose the room where the telehealth visit will take place. Many of my patients do choose the bedroom because it's a private place. They can show me any affected body parts. It's just a little easier, but don't suggest the bedroom. That could be triggering to somebody. Be sensitive to patients' hesitancy to reveal personal space. I can share a story about that later, about one of my veterans who was very resistant to telehealth until she figured out a way to drape her apartment, which she was ashamed of. So always be sensitive. Don't make comments about people's homes or backdrops, even if they have a very nice one. And again, we have safety concerns about using telehealth during the pandemic. I've told you that many of you already know there are increased rates of IPV, elder abuse. Patients may wish to do visits from the car, the garage, the backyard. I had a patient do a telehealth visit with me from the Park Street T, which I was really horrified about, but she insisted that it was where she felt comfortable and safe. Headphones and earbuds are important for patients. I'll tell you why. If you're doing a telehealth encounter with a patient and they suddenly look up, they look vigilant, it looks like somebody came into the room. If they're wearing something, you can say, "Are you okay?" And they can answer yes, no. You can ask them, "Do I need to call 911?" And they can answer yes, no. Do we need to disconnect? Can I call you back on the phone? Yes, no. And patients should always know that the topic of conversation can change. So I tell my patients that, if we're talking about bruises on your leg and someone walks into the room and you change the subject to the weather, I will know that means that you no longer have privacy. Suspected IPV elder abuse is never a reason to withhold a telehealth visit. Connection may be vital for that patient or that family, but be aware of environmental cues. And this is just a slide that shows you eye contact. And then this is a slide that shows you lighting. And our patients who've experienced trauma want to see our entire face. They don't want to see, a face in shadows. I know that a couple of folks on the leadership team have a lot of experience in caring for ourselves and wellness. So hopefully we can integrate that into the conversation. Be aware of the emotional impact of working with a highly trauma exposed population. Know that your own history may inform how you respond. I think that my fuse has become shorter. There is something called the window of tolerance that we can talk about later if we have time. And our patients who've experienced trauma are sometimes very activated and sometimes they're very numb. And in the middle is the ideal window of tolerance. And I feel like I have at times during COVID gotten frustrated with people way more easily than I normally would. Working with a highly trauma exposed population can result not only in vicarious traumatization or compassion fatigue, but it can also result in compassion satisfaction and vicarious healing. It can be very rewarding. Small changes really matter. It's very easy to say, why does it matter if I'm trauma informed when patients walk into the hospital lobby and get re-traumatized? And I just remind you that starting small, starting with your clinic, those of you who are students, starting with a lecture, starting with a brown bag lunch, you're making a really big difference. And so again, I want to save time for discussion. Know that systems transformation is part of trauma-informed care, but what you do really matters from day to day. And those of you who are in training know that if you change one thing tomorrow, even if it's the way you examine the thyroid, you're going to have 20, 30, 40 years of medical practice, and you're going to change and affect patients' lives, because our patients, when they become traumatized in medical settings, don't come back, they don't engage. So just want to remind you of this quote from Elizabeth Kubler-Ross: the most beautiful people we have known are those who have known defeat, known suffering, known struggle, known loss, and have found their way out of the depths. And it really is inspiring to work with people like my patient Eileen, who's a World War II veteran, who passed away at the age of 95 a couple of years ago. That people who have healed are incredibly inspiring people to work with. So thank you for your attention. I will just point you to some resources that you'll have access to later. And I think we'll go ahead and have some time for discussion.